My talk, I'm going to discuss strategies to target calreticulin and MPNs, approaches to individualizing JAK inhibitor therapy in myelofibrosis patients, and I'm also going to provide some updates on novel therapeutics under evaluation in later lines of therapy and frontline. Mutations in the gene for calreticulin were first identified in essential thrombocythemia and primary myelofibrosis back in 2013, and together with JAK2 and MPL are the driver mutations described in the majority of MPN patients. In this early survey paper by Klempfel and colleagues, mutations in CALR were described in about 25% of ET patients and 35% of PMF patients. There are two types of CALR mutations commonly described. The most common is the type 1 mutation, which is a deletion of 52 base pairs. And then there is also the type 2, which is a 5 base pair insertion. CALR is a unique therapeutic target because of differences between it and normal CALR. The insertion and the deletion mutations result in a unique protein which has an altered C terminus. This altered protein loses the signal that causes it to be recycled from the cell surface back into the endoplasmic reticulum, and it also stabilizes the thrombopoietin receptor dimer, which results in downstream constitutive signaling. This unique protein has been the target for antibody and other small molecule development. One of the plenary abstracts was a report of a fully human IgG1 antibody targeting mutant CALR that was developed by Incyte, and this is INCA 033989. The study presented preclinical data supporting the efficacy of 33989. The authors first used cell lines to demonstrate that the antibody could inhibit thrombopoietin receptor dimerization, which is shown here at left in this dose-dependent manner. They also looked to see if the antibody decreased aberrant signaling induced by mutant CALR. And as you can see here in the panel at right, in the left-hand side, you can see increased signaling of STAT3, STAT5, ERK, and mTOR with mutated CALR, and this is decreased at right after the antibody exposure in the blue. They also showed that a decrease in cell proliferation was specific to mutated CALR cells and did not impact the mutated JAK2 cells. This is shown in the figure at right, with increasing cell death with increasing antibody dose, which is only seen in the mutated CALR cells. The authors also examined primary patient cells. For these studies, they used CD34 stem progenitor cells from healthy donors, as well as MPN cells. In the middle panel, you can see that only 33989 impacted mutated CALR progenitor cells, which is shown in the blue. And on the right, you can see that the impact is only on megakaryocytes in mutated CALR cells and not in JAK2 mutated cells. The last part of the presentation, they examined the impact of the antibody in a mouse model of essential thrombocythemia. And then they found that platelet counts and numbers of megakaryocytic progenitors were decreased in mice receiving the antibody. And we know that megakaryocytes are important in MPN pathology and are drivers of myelofibrosis. So in conclusion for this interesting presentation in the plenary session, INCA 033989 is a potent antagonist of mutant calreticulin function. And these data provide a strong rationale for the clinical investigation of 33989 in MF and ET patients with CALR mutations, and a phase 1 study of this agent is currently in planning. So we all know for the management of primary myelofibrosis, there are several JAK inhibitors available in the US, which are indicated for patients with symptomatic myelofibrosis. Ruxolitinib and fedratinib are indicated for patients with platelet counts greater than 50,000, and pacritinib in the US was approved for patients with low platelets. However, as many of you know, managing these patients with MF with moderate to severe cytopenias is difficult, and several abstracts at ASH in 2022 focused on approaches to individualize JAK inhibitor therapy in these patients. Anemia is a significant problem in myelofibrosis patients and is worsened with treatment with JAK inhibitors. In a recent survey of 1,109 PMF patients, 37% of these patients had severe anemia. We also know from the COMFORT studies, which resulted in FDA approval of ruxolitinib, that 45.2% of patients in Comfort 1 and 42% of patients in Comfort 2 developed grade 3 anemia or higher. Momelotinib updates were presented at the 2022 meeting. Momelotinib is not only an inhibitor of JAK1 and JAK2, but it also inhibits ACVR1. ACVR1 inhibition results in decreased hepcidin expression, which in turn leads to increased erythropoiesis and increased hemoglobin. Data from the earlier study, Simplify 1 and 2, showed similar spleen responses and improvements in constitutional symptoms versus ruxolitinib. Spleen response and symptom improvement are key primary endpoints in myelofibrosis trials. Most importantly, grade 3 or higher anemia was lower with momelotinib treated patients, and as shown here for Simplify 1, was seen in only 6.1% of patients who received pacritinib versus momelotinib versus 22.7% receiving ruxolitinib. So Dr. Aaron Gerz presented updates to the phase 3 Momentum study, which was a study of momelotinib versus danazol in patients with anemia and who had also received prior JAK inhibitor treatment. So patients on this study were randomized 2-to-1 to momelotinib versus danazol. Top-line results at week 24 were presented at the ASCO and EHA meetings in 2022, and Dr. Gerz presented the data regarding the open-label continuation and crossover phase of this study. For the primary endpoint, which was total symptom score response at 24 weeks, this was achieved in 24.6% of momelotinib-treated patients versus 9.2% of danazol-treated patients. Spleen volume responses were seen in 23.1% of momelotinib-treated patients versus 3.1% of danazol-treated patients. Sorry about that. So this was a heavily pretreated patient population, with 50% of the patients being transfusion dependent in this study. And this is an overview of the design of the study. So the crossover continuation was as follows. 94 patients, or 72.3% of the momelotinib treated patients, completed the 24 weeks, and almost all entered the open label extension. 66 completed this. And for danazol-treated patients, this was 38, or 58.5% of patients completing initial 24 weeks, and 41 patients, which also included early crossovers, entered the open label phase, and 28 completed it. As shown here, you can see that symptom responses that were achieved at 24 weeks were maintained through 48 weeks. Additionally, new responses were seen in patients who crossed over to momelotinib, with 29% achieving responses, and additionally, 20% of non-responders on momelotinib became responders by 48 weeks. With regard to transfusion independence, this was seen at week 24 in 31% of patients in the momelotinib group versus 20% of the danazol group. And 90% of the momelotinib-treated patients and 77% of the crossover patients were able to maintain this response. The waterfall plot here shows spleen response, and this is spleen volume reduction 35%, which refers to a 35% or greater reduction in splenic volume. And this was achieved in 23% of momelotinib-treated patients versus 3% of danazol-treated patients. And again, this was maintained by all through week 48. So in conclusion, these updates do support momelotinib as an effective treatment in MF patients, especially in patients with anemia, and the FDA has granted fast-track review to momelotinib. The FDA approved pacritinib in the management of intermediate or high-risk PMF or secondary MF in 2022. It's indicated for patients with thrombocytopenia with platelets less than 50,000, and approval was based on the results of the phase 3 PERSIST-2 study, which compared pacritinib to two doses to best available therapy. For patients receiving the dose of 200 milligrams twice daily, 29% achieved SVR35 versus 3% of patients receiving best available therapy. And the phase 3 Pacifica study is ongoing. So at the 2022 meeting, Dr. Stephen O presented data on the impact of pacritinib in MF patients with anemia. In preclinical studies, the investigators first assessed the potency of various JAK inhibitors against ACVR1, including a control, that you can see here at the left. As shown in the dark blue, pacritinib had significant potency against ACVR1 and was actually reported to be 4 times more potent against it versus momelotinib. Additionally, and similar to momelotinib, pacritinib also decreased hepcidin, which theoretically should then contribute to increased erythropoiesis. The authors then retrospectively examined patients with anemia and PERSIST-2. They specifically focused on patients who were not transfusion independent at baseline and who had received at least 12 weeks of therapy on study. For patients receiving best available care, this included ruxolitinib treatment in 42% and danazol erythropoiesis stimulating agents, IMiDs, and steroids in 26% of patients. The authors reported that transfusion independence conversion rate was higher in patients receiving pacritinib versus best available therapy, and they looked at this in 2 different ways. They used the Gale criteria, which is no red blood cell transfusions over a 12-week period, and they also used the simplified criteria, which also includes no hemoglobin less than 8 grams per deciliter over that 12-week period. For the Gale criteria, transfusion independence conversion rate was 37% in pacritinib-treated patients versus 7% in best available therapy. Additionally, 49% of pacritinib-treated patients achieved a 50% or greater reduction in transfusion versus only 9% of patients receiving best available therapy. And so in conclusion, with data presented by Dr. Owen colleagues, this supports the use of pacritinib. It seems to be a good choice for patients not only with thrombocytopenia, but also in patients with anemia. So as we all know, there is clearly a need for therapeutics for patients with myelofibrosis. Risk stratification for MF patients is driven by clinical features such as anemia, constitutional symptoms, and blast counts. Our newer risk score calculators are also driven by porous cytogenetics and the presence of high-risk mutations such as ASXL1, SRSF2, EZH2, IDH1 and 2, and U2AF1. As I show here at left, patients with high risk or very high risk scores have abysmal outcomes with 10-year overall survival of only 13% and less than 5% respectively. So with this background, there were a large number of clinical trial updates for various therapeutics with activity in myelofibrosis at the ASH 2022 meetings. And I've summarized these here. These included updates of signal transduction inhibitors such as PI3K delta inhibitors, the telomerase inhibitor imetelstat. We also heard long-term results of combinations of bisremi, which is a pegylated interferon alpha 2A, together with ruxolitinib, and bisremi was recently approved in the EU and the US. We also heard updates on apoptotic pathway inhibitors such as navitoclax and epigenetic modifiers, including the BET inhibitor pelabresib. I think this is a really exciting time in the myelofibrosis field, but I only have time for one update, and so I've decided to present data by Dr. Mascarenhas on pelabresib combined with ruxolitinib in treatment-naive myelofibrosis. So BET inhibitors are epigenetic inhibitors, and they work through multiple mechanisms. They target transcription of key genes that ultimately contribute to cytokine suppression, and this in turn leads to improvement in patient symptoms and also reduces inflammation that leads to myelofibrosis. Manifest is a phase 2 study, which is investigating pelabresib in myelofibrosis and essential thrombocythemia. So at the ASH 2022 meeting, Dr. Mascarenhas' presentation focused on the results of Arm 3, which is the upfront pelabresib and ruxolitinib arm. And for this arm, the primary endpoint was spleen volume reduction of 35% or greater, and a key secondary endpoint was the total symptom score reduction of 50% or greater by week 24. So as shown here by this waterfall plot, spleen volume responses were seen in 68% of patients, and TSS 50 was seen in 56% of patients. Overall, pelabresib was generally well tolerated. The most common hematologic side effects, non-hematologic side effects, were GI side effects. And as we often see on these studies, there was a significant amount of heme toxicity. Lastly, for patients receiving pelabresib, we also saw improvements in myelofibrosis. So 27% of patients showed at least a 1-grade improvement at week 24, and 40% of patients saw an improvement at any time. We also found that spleen volume response is correlated with decreases in JAK2 allelic burden. And as I show here in the middle panel, these were also associated with declustering of megakaryocytes in the bone marrow. So as noted, this is an exciting time, and we may see some additions to the treatment arsenal of myelofibrosis in the future. And there are several ongoing important phase 3 studies, and these include combinations with ruxolitinib frontline with pelabresib and navitoclax, also some add-on combinations to ruxolitinib in the second line and beyond. And there is also the ongoing phase 3 study of monotherapy with imetelstat in the second line and beyond. So I'm now going to switch gears a little bit and focus on updates for chronic myeloid leukemia. And I'm going to focus on the best strategies to treat chronic phase CML resistant and intolerant to second-generation TKIs. And very briefly, at the end of this presentation, I'm going to focus on some new therapeutics in the front line. So in 2023, in the front line, we have the first generation TKI imatinib and the second generation TKIs dasatinib, nilotinib, and bosutinib. For T315I mutated CML and in the third line and beyond, we have the third generation TKI ponatinib and the myristoyl pocket inhibitor asciminib, and these are available in the US and the EU. We know that outcomes for patients on later lines of therapy are poor, and what I show here are data from 582 patients treated at MD Anderson through 2015 in chronic phase who received more than one TKI. As you can see here, overall survival and transformation-free survival are poor with each subsequent line of therapy. And consequently, a big question in the field is how best to sequence TKI therapy in later lines. I know that ponatinib is not available in India, but I think the data for ponatinib make a case for the importance of third-generation TKIs when available in later lines, especially in patients who are resistant. And I will, at the end of this presentation, discuss 2 new third-generation TKIs that are being developed in China and India that are undergoing evaluation and may be available in the future. The OPTIC study is a phase 2 study designed to determine the optimal ponatinib dose that maintains efficacy but minimizes arterial occlusive events such as cardiovascular, cerebrovascular, and peripheral arteriovascular events. For the OPTIC study, patients were randomized 1:1:1 to ponatinib at 45 milligrams, 30 milligrams, or 15 milligrams daily. For patients enrolled in the 30 and 45 milligram cohort, there was a mandatory dose reduction that occurred once BCR-ABL was less than or equal to 1% to 15 milligrams daily. And BCR-ABL of less than or equal to 1% is the molecular equivalent of a complete cytogenetic response. The primary endpoint was BCR-ABL of less than or equal to 1% at 12 months. As published in 2021, we found that the 45 milligram daily dose had the highest efficacy. There was also a dose-dependent impact on arterial occlusive events, but overall, with the dose reduction strategy, the rates observed were lower than what we had seen on the phase 2 PACE study, where patients continued on the higher dose without a mandatory dose reduction. At the 2022 meeting, Dr. Cortez and colleagues presented updates to OPTIC at 36 months, and this continued to confirm that responses were durable. Additionally, as we had previously reported, BCR-ABL of less than or equal to 1% was highest in patients who received the 45 milligram dose, and BCR-ABL of less than or equal to 1% was 60.2% in this group. With regard to arterial occlusive events, the rates remained consistent with prior reports. Longer-term follow-up also highlights an important point that starting dose is particularly important for patients with T315I mutations, and this is shown here in the middle panel. You can see here that far fewer patients achieved the primary endpoint on doses lower than 45 milligrams daily, and this was in contrast to patients who had other mutations or who had no mutations, where you see efficacy at lower doses as well. So with this background, the question then becomes, what is the best third line therapy? Is it ponatinib or is it selecting another second generation TKI? And Dr. Jabbour presented a propensity score analysis that addressed this question at the ASH 2022 meeting. For this study, they looked at 354 patients. This included 204 patients treated at MD Anderson on second generation TKIs. And for the ponatinib treated group, this was patients enrolled in PACE and OPTIC. A number of response outcomes were assessed and then performed a 1-to-1 propensity matching on key covariates. So as you can see here, with regard to overall survival was better for ponatinib treated patients versus 2G TKI treated patients, both before and after matching. And similar findings were also seen for progression-free survival. In this presentation, the authors demonstrated that ponatinib was superior to 2G TKIs in regard to the cumulative 2-log reduction in BCR-ABL, progression-free survival, and overall survival. And this difference was even more evident for patients who had high burden of CML disease with BCR-ABL of greater than 1%, and suggests that these patients in particular will benefit from a potent third-generation TKI, such as ponatinib. So with this background, I'd like to present data for 2 third-generation TKIs that were presented at ASH last December. And the first is olverembatinib, and the data for this phase 1 study in the US were presented by Dr. Jabbour. So olverembatinib is a novel third-generation TKI, which has highly potent activity against BCR-ABL and also all mutated BCR-ABL, including T315I. In the 2021 ASH meeting, we heard updates of 101 chronic phase and accelerated phase patients treated in China, and the authors at the meeting in 2021 reported complete cytogenetic responses in 69% of patients and major molecular responses in 54% of chronic phase patients. In the US study, this was a phase 1 study, and our key primary endpoint was PK, and our key secondary endpoints were safety and efficacy. And we enrolled patients in all phases of CML with resistance or intolerance to 2 or more TKIs. And we also excluded patients who had a complete cytogenetic response. Notably, as I show here in the red box, we did not exclude patients with cardiovascular comorbidities. And as you can see here, 50% or more of patients had CV comorbidities, of which hypertension was the most common. Additionally, this was a heavily pretreated patient population with approximately 50% of patients having received 3 or more lines of prior therapy. And we also had a high proportion of patients who were resistant to ponatinib, and this was 70% for chronic phase CML. So olverembatinib response is shown here for chronic phase patients by dose cohort on the left, prior ponatinib failure in the middle, and by T315I mutation status at right. So for the entire group, a complete cytogenetic response was achieved in 77.8% of CP-CML patients and major molecular response in 43.5%. As you can see in the middle, in the right-hand panel, similar efficacy was seen in T315I mutated patients. And as shown in the middle panel, we saw good efficacy in ponatinib failures, with 88.3% achieving complete cytogenetic response and 43.8% achieving major molecular response. We found that olverembatinib was well tolerated with the expected hematologic toxicities that we see in these heavily pretreated patients. The main non-hematologic toxicities were CK elevations, AST, ALT elevations, lipase elevations, headaches, nausea, and myalgias. So in summary, for olverembatinib in resistant CML, we saw efficacy in patients with refractory CP-CML as well as in advanced Ph-positive leukemias, which I didn't present, and in patients with or without T315I mutations. It was safe and well tolerated up to doses of 50 milligrams every other day. And with regard to PK, we did see a dose proportional increase in exposure as we went from 30 to 50 milligrams every other day, and comparable plasma exposure with a similar PK profile between Chinese and the US patient population. Updates for vodobatinib, which is developed by Sun Pharma in Mumbai, by line of therapy were presented by Dr. Cortez. So vodobatinib is a potent third-generation TKI with efficacy against most mutations, but not against the T315I mutation. As I show here at right, it has less off-target effects versus ponatinib. The study design is shown here, and this included an accelerated dose escalation followed by the more standard 3+3 escalation, which has been followed now by an ongoing dose expansion phase. The key endpoints for this study are MTD and the recommended phase 2 dose, as well as safety and efficacy. For this subgroup analysis, which was presented by Dr. Cortez, patients were divided into line of therapy. And so 2T here is patients who receive 2 lines of therapy or less, and 3T is patients who receive 3 lines of therapy or more. And the patients were also further stratified by whether they had received prior ponatinib or asciminib. Demographics are shown here, and as you can see in the red box, this was a heavily pretreated patient population. And with regard to efficacy, as expected, lower rates of major cytogenetic response, which was a primary endpoint, was seen in later lines of therapy, with 60% achieving major cytogenetic response in the 2T group versus 43% in the 3T group. For ponatinib-treated patients, major cytogenetic response was seen in 44%. They then performed landmark analysis at 6, 12, and 24 months, which is shown here, and cytogenetic responses are shown at left and major molecular response at right. And as you can see for the entire group, cytogenetic and major molecular response rates increased over time, with 55.8% achieving a complete cytogenetic response by 24 months and 34.9% achieving a major molecular response by 24 months. Shown here is a similar analysis for cytogenetic response now divided by line of therapy and prior ponatinib exposure. So if you follow the green, you can see that by 24 months, 66.7% of the 2T patients achieved a complete cytogenetic response, and 50% of the 3T patients and 50% of patients who previously received ponatinib achieved a complete cytogenetic response. With regard to major molecular response by 24 months, this was seen in 26.7% of 2T patients, 42.9% of 3T patients, and 50% of ponatinib-treated patients. With regard to progression-free survival at 2 years, this was 73.7%, and at 4 years was 63.3%. Vodobatinib was generally well tolerated, and the most common treatment-emergent adverse events were GI toxicities as well as musculoskeletal, and these occurred more frequently in 3T patients versus 2T patients. With regard to hematologic treatment emergent adverse events, these were most commonly seen in these heavily pretreated patients, and this was particularly notable for thrombocytopenia, which is a common finding in our clinical trials. And again, this was more common in patients who were 3T versus patients who were 2T. So in conclusion, for the vodobatinib phase 1 study, vodobatinib continues to demonstrate durable efficacy and safety in CML, including patients with failure or intolerance to 3 or more prior therapies, including ponatinib. Does not have activity against the T315I. Major molecular responses were reported in 40% or more of patients with resistance or intolerance to 3 prior TKIs, as well as patients who received ponatinib. Most adverse events were manageable with dose reductions and modifications. And with regard to cardiovascular adverse events, these were predominantly low grade and were consistent with what we see in this heavily pretreated and advanced treatment population. And vodobatinib is now being evaluated in a phase 2 study with patients refractory and or intolerant to 3 or more TKIs, including ponatinib, at the recommended phase 2 dose of 174 milligrams. So to close this talk, I'd like to briefly talk about some new therapeutics frontline. So in the US and the EU, asciminib has been approved in the third line and beyond, and for T315I mutated CML. And asciminib has a novel mechanism of action. As shown in the green, it binds to the myristyl pocket rather than the ATP binding site, which is shown in purple, and thereby inhibits BCR-ABL kinase function. Ongoing studies worldwide are examining asciminib in earlier lines of therapy and also in combination with TKIs. And Dr. David Young presented interim results of the ASCEND CML study in Australia, which is using asciminib in the front line. So this study in Australia enrolled 100 patients and has 2 co-primary endpoints, early molecular response at 3 months and major molecular response at 12 months. As shown at right, at 3 months, 92% of patients achieved an early molecular response and 47% a major molecular response, and 13 patients a deep molecular response at 3 months. And this demonstrates the potency of asciminib in the frontline setting. We know that achieving deeper molecular responses earlier may lead to more patients qualifying ultimately for TKI discontinuation. And a US study is planned in the front line through the Cure CML consortium. And with that, I'd like to bring my talk to a close, and I'd like to thank you very much for your attention today. And I'm happy to take questions about these ASH updates and any other questions. Thanks again.
Thank you, Dr. Vivian, for the wonderful presentation. You covered very nicely the recent updates of the MPN as well as the CML. So I request my extreme panel to raise hand, and I will pick up the questions one by one. So I already see all questions from Dr. Faima. Dr. Faima, please go ahead. Dr. Faima, please go ahead.
I think you're on mute.
Yeah.
So.
Faima, we are not listening you.
Yeah. He's muted.
Yeah.
He seems to be muted.
I think she left also, I think.
Faima, you are muted.
Faima, yeah.
No, Faima, still you're still muted.
Faima, we are not able to hear you.
Faima, unmute yourself, Faima. You can take question from Sriram Kane.
Does she want to put her question in the chat and I'll read it?
Yeah, Faima, you can put your question in the chat box. Sriram Kane, you can ask your question.
So in the meantime, there is a question from Dr. Sitaram Anandam. Efficacy of asciminib in CML, in CPA, accelerated phase and blastic phase.
Great question. We don't have a lot of data. Most of our clinical trials actually are in chronic phase. And so our indications for approval in the EU and the US are in chronic phase. So I will say in my own practice, I have managed to get asciminib approved for one patient. Because of its label indication, asking for it in blast phase may be a little bit difficult because it says. All right, can you hear me?
Yeah.
All right, now I unmuted myself. So I do think it has some efficacy in blast phase. It is very potent inhibitor of BCR-ABL. I will say for patients who have blast phase CML, I sometimes prefer the potent third generation TKI ponatinib over asciminib. And the rationale for that is asciminib is a very pure inhibitor of BCR-ABL. It's well tolerated because it has very little off-target effects. Ponatinib, on the other hand, is not a clean drug, and it actually hits a number of other targets which lead to the toxicities, right, the cardiovascular toxicities. But on the other hand, as shown by Dr. Brian Drucker, it actually targets other things that are relevant in CML disease progression. And so ponatinib may be an appealing choice because it's not such a clean BCR-ABL inhibitor. And if we think of progression as sort of a movement away from being dependent only on BCR-ABL, it might be important to hit other targets as well. So my typical go-to tends to be a third generation TKI. And of course, in the US, I have ponatinib. But I'll say olverembatinib is actually showing very impressive data in advanced phase CML. I haven't seen the data for vodobatinib, but it also shows some efficacy in advanced phase as well. So if you have access to asciminib, I would choose it potentially over a second generation TKI, but I might choose a third generation TKI instead if I have access to it.
But just follow up of this question. So in your clinic, how do you choose ponatinib versus asciminib?
Yeah, good question. So this is how I choose. If I have a patient who is resistant with a high burden of BCR-ABL, and whether that's greater than 1% or even greater than 30%, and they have no mutations, I'm probably going to select ponatinib next line. On the other hand, if I have somebody who's now on third line therapy, who's demonstrated a response to therapy, but has multiple intolerances, hands down, I'm going to choose asciminib. I do think that for patients who are truly resistant, who may be BCR-ABL independent, that the third generation TKI might be a better choice. And, we don't really know the answer to that question, right? Because, the ASSEMBLE study chose a fairly low-hanging fruit. They went up against bosutinib, right? And they showed greater efficacy with regard to the endpoint, which probably was not unexpected. And the question is, what if you had gone head-to-head with ponatinib? So I'm a little bit in mixed minds about it. Had they gone up against ponatinib and not met their primary endpoint, I wouldn't have access to the drug. And I have a lot of patients on asciminib who love it because it has very few side effects and they have excellent quality of life. But, on the other hand, I'm not convinced it's more potent than ponatinib. And so for truly resistant patients, particularly those without mutations, I reach for the third generation TKI ponatinib.
Yeah.
All right.
Yeah, Dr. Faima, please.
Am I audible now?
Yeah.
There was some problem.
Yes.
Hello, ma'am. Such a lucid talk. Literally loved it. We don't have any access to third gen TKI. So, my question is more of a practical one, which I face in clinics. Yeah. We have a single day OPD for CML every Wednesday. We see around 200 patients every Wednesday of CML. So there are certain patients whose BCR-ABL was never in major molecular response. It's less than 1%. It's 0.8, 0.9. And even on dasatinib, it's still the same. And what we do is we have PCR for TKD mutations. We do send that. We don't find any mutations in this cohort. And there are certain young patients whom I was pretty concerned about this persistent BCR-ABL positivity. So I do send it for NGS as well to check for TKD mutations. And still, I don't get any mutations on that as well. What kind of patients are these? What should I do about it? For example, if they are on imatinib, should I really put them on a second gen TKI and see, or if they're already on dasatinib, what can I do about it? Like, I just
Yeah.
want to
So great question. What dose of the second generations are you using? Full dose?
full dose. Yes, ma'am.
Okay, great.
400
So
per
that
meter.
is the question. So I would say, there was a time early in our management of CML when 0 was the goal for everyone, right? And I'm going to say 20 years down this road, we recognize that overall survival benefit really comes from achieving that complete cytogenetic response with BCR-ABL less than 1%. So I certainly have a cohort of older patients who have tolerance issues, and I don't really aim for deep responses. I mean, if they get there, terrific, but if they don't get there and they're somewhere between 0.1% and 1%, I'm probably going to accept that. And MD Anderson has shown data that even a major cytogenetic response confers some survival benefit. Now, this may not be a great argument for your younger patients who are like, please, someday let me be eligible for TKI discontinuation. But, that can be a difficult goal to achieve, right? So how do you get there? And you're right, I'm lucky. In the US, I have a lot of therapeutics to choose from. I was kind of wondering whether in the future, if we saw good data, you would have access to olverembatinib or vodobatinib, for example, which are potent drugs, and maybe vodobatinib could be a drug, for these patients in the future. When you switch from TKI to TKI, it can't be guaranteed that you're going to actually achieve these deeper responses. So in my own anecdotal experience, and this has actually also been shown by several Australian studies, on imatinib, if you didn't meet the major molecular response, they switched you over to Tasigna. And so a good proportion of patients actually achieved that goal. And so you can, the question is, it comes with potentially cardiovascular toxicities with Tasigna, risk for pleural effusions with dasatinib. But I think for young patients, I would definitely go ahead and think about doing that, provided that that's an affordable thing. Sometimes these drugs are more expensive. I think you have access to generic dasatinib in India, so perhaps not a problem, versus us, where we're still waiting for the generic indication to come. And so that's reasonable, but it doesn't always work. But I think for a younger patient, I do that. For your older patients with comorbidities and toxicities, you don't have to. I don't know what the magic number is, but we've changed the NCCN guidelines to reflect the fact that you don't absolutely have to achieve deep molecular response. Major molecular response is always my goal, but I have patients who do lie between 0.1 and 1% who have good life expectancy.
This is absolutely, thank you so much, ma'am, for the explanation. I'm happy with older patients having this, but what about the young patients? Then what we do is we try to increase from first gen TKI to second gen. Dasatinib is damn cheap, dirt cheap here. It's less than 5,000 INR. Like, I convert into US dollars, it would be like $10 or around $10 to $15 per month. So that's the rate of dasatinib we get. So we give dasatinib. Even then,
I agree with you. Yeah, I would do the same thing.
Yeah, the patient does not attain DMR, deep molecular response,
even after dasatinib.
And again, we repeat this PCR and NGS platforms for TKD mutations, and we don't find anything. And the patient is in hematological response as well. There is no progression of the disease.
Yeah. So, you always have the opportunity to increase the dose further, right? We used up to 140 milligrams. The problem is that that does come with increased toxicities and increased risk for pleural effusion, which is a possibility. It turns out not everything in CML is driven by BCR-ABL and, mutations. And so there might be some other mechanism here that dasatinib is not hitting, which is unfortunate. Although I will say a number of my patients are not completely upfront with how adherent to therapy they are with me. And of course, I can never really know that. So sometimes that's another reason.
Do you think this warrants sending for other myeloid mutation sequencing? Especially in younger
I think it would be intellectually interesting, but I don't think you'd be able to use that data, right? Even I collected on every single one of my patients. I've got 200 patients that I've sequenced just to see what kind of mutations they have, and sort of in keeping with what's been published from Australia and Singapore. We do actually see mutations like ASXL1 and RUNX1, and they're very rare in chronic phase. I'll say this. Much more common as you progress to blast phase. But there isn't other than pay attention to a chronic, like if I see RUNX1 and somebody's not responding, that's somebody I'm a watcher. Are they going to be an early progression patient? But I will say up front, I still put them on a second gen TKI and watch how they do. So I think it's really interesting to know, but so far we haven't really provided great guidance on how to use that information in clinical practice.
Thank you, ma'am. Thank you so much for elegantly explaining. Thank you.
Thank you, Dr. Faima. So next question is from the chat box, Dr. Kannan.
Yeah.
When will you consider for allo-BMT in myelofibrosis patient? And the second part of the question is, in a low-risk patients of myelofibrosis with ASXL1 mutation, will you go for transplantation or not?
Yeah. All right. And then there's another question in the chat box too. So the first question is, who do I transplant? The second question is, what do I do with ASXL1? And the third question is, what's the role of ESA in the treatment of anemia during primary myelofibrosis? Yeah. So, I tend to use, if you've got a low EPO, less than 500, I do think actually ESAs can be very useful. In that group. Unfortunately, if you have a high erythropoietin, the success rate with ESAs is less. But generally, I think it's a reasonably safe strategy to try. Certainly for deletion 5q, we use lenalidomide in the US. I'm going to say there's emerging data that suggests that maybe in other cancers, the use of lenalidomide can sort of promote cancer. And so I've started to be a little bit reluctant in a young person to jump to lenalidomide right away. And so if you've got a low EPO, I might actually reach for the ESA. All right, so who do I transplant? So I kind of follow the algorithms, and I actually transplant patients who are intermediate 2 and high risk with myelofibrosis. Of course, a lot of times these are older patients with a lot of comorbidities, so not everyone really can get to transplant. Of course, transplant is a different place now than it was 30 years ago with reduced intensity conditioning, et cetera. And so those are the patients, if I see intermediate or high risk, I'm going to lower your burden of disease. I think JAK inhibitors before transplant are critical. And then we'll move on to transplant. But I'll say that despite me saying that, a lot of patients don't end up getting transplanted. So ASXL1, that's an interesting question, right? We said ASXL1 is high risk. This is high risk, but honestly, I think it's high risk in combination with other mutations. And now we have new data to support that as well, too. So maybe 5 years ago, I would have thought about transplanting somebody with ASXL1 alone. But I think at this point, I'm a little bit more careful. I will say, looking at the mutation profiles of a lot of patients with, myelofibrosis, we see this whole slew of mutations. And so normally we have other high-risk mutations present as well.
Yeah. Thank you, Dr. Vivian. So Dr. Gopinath, please go ahead.
Yeah. Good evening, ma'am. Thanks for the elaborative talk. Just if a patient on myelofibrosis while on ruxolitinib progresses to blast crisis, so what is the ideal induction strategy? And will we be continuing this patient with ruxolitinib as the same dose, or how do we modify it? And what is the ideal induction strategy? See if it is a 60-year-old patient.
Yeah, I will come out and say that I don't think we have an ideal strategy. I will say here at the Fred Hutch, we are the most aggressive doctors on the planet. So we actually will give plan for transplant, and we'll actually give intensive induction chemotherapy. And that is not necessarily the strategy I recommend unless you're heading right into transplant, because it's set up. What is a pretty popular regimen in the US, and one that actually came from data at Memorial Sloan Kettering, and a colleague of mine has the clinical trial here, is a combination of ruxolitinib, with hypomethylating agents. And so that is a common strategy to use. What is the ruxolitinib dose? I think we often will still follow the guidelines and dose reduce the ruxolitinib in accordance with the degree of cytopenias they have. I will say using these regimens takes a little bit of time. And of course, these patients, the biggest problem is, of course, the cytopenias, right? And so the fact that they end up having a number of infections, et cetera. But this is like one regimen that we typically reach for. Because we don't really have a lot of great stuff in this space, we also have a number of clinical trials. We generally at the Fred Hutch allow patients with more than 10% blasts, at least on investigator-initiated studies, to join our AML patients in those studies as well. And so our go-to typically isn't necessarily to use a hypomethylating agent plus ruxolitinib, but for a fit person who seeks us out at the Fred Hutch to perhaps use an AML regimen to debulk before transplant. So I hope I've sort of answered your question. So I think hypomethylating agent plus Rux is a reasonable possibility. And whether you use 10 BID or 5 BID as dose, I think is reasonable.
Okay. Thank you, ma'am. How do we understand the biology? Like this patient has progressed on a ruxolitinib therapy. So would continuing ruxolitinib therapy during that induction also, will it, abort the oncogenic process? How do we understand the biology about it?
Yeah, well, I think if you progressed on ruxolitinib, it won't abort the process. I think unlike CML, where we have, we know CML is driven completely by BCR-ABL, at least in chronic phase, right? And that's the reason it's the superstar of the targeted world. Unfortunately, as useful as JAK inhibitors are, myelofibrosis is not really only driven by inhibition of the JAK. That said, if you take away the JAK inhibitor, patients can get symptomatic because there is some benefit. So the disease is progressing. And so removing it, I don't like to do that because it might be doing something. But clearly, if you've progressed on this drug, you can certainly reach for another JAK inhibitor. But for patients who have accelerated phase or blast phase of myelofibrosis, I'm not necessarily expecting that switching to another JAK inhibitor will help. But I guess what's maybe exciting in this space is patients who have these bad cytopenias, right? So in the US, we have pacritinib for the low platelets, which might be a little gentler on that lineage. And then if the FDA chooses to approve momelotinib in the future, we may have this, which might be a little bit easier to use than ruxolitinib in these patients.
Thank you, ma'am.
So next question is from the chat box, Dr. Shailesh. What is your opinion regarding adding pioglitazone in addition to imatinib in case of suboptimal response to imatinib?
Yeah. So I will say in the US, we don't have a great giant experience with pioglitazone, but absolutely, in Europe and in other places, they have examined it in combination with TKIs. I think most of the data that I've seen was the study where they were kind of adding it on in a way to deepen molecular response and then also to sort of facilitate TKI discontinuation. So I don't have a ton of experience using this drug, so I don't know how successful it really is in deepening response. So I think if you have access to it and it's really inexpensive and you don't have access to another more potent TKI, it might be reasonable to try, but in my own practice, I haven't actually used it and I haven't seen it go forward much beyond the European studies.
Dr. Vivian, I have a quick question. When you decide about the ruxolitinib dose in myelofibrosis, it is a platelet number dependent. So to start with, suppose the patient's platelet count is a little bit lowish than the 50,000 mark, so 40,000, 35,000, 45,000. So how do you do that? You start ruxolitinib or you just wait or this is related. Yeah, what do you do?
Well, I know you're supposed to follow the package insert, but at some level, patients sometimes get a little bit better over time, right? So you don't want to underdose them. So you're supposed to use 5 to 10 milligrams BID. So honestly, in my own practice, I'd probably start at 10 milligrams BID rather than the 20 milligrams. And see how things go with careful follow-up. Generally, if you're sitting at 45,000 to 50,000, you're not going to have a spontaneous CNS bleed, right? Where it really gets nerve-wracking is when somebody's sitting at 10,000 to 15,000 and you don't want to drive them down and have a CNS event.
So one more question regarding the MDS-MPN overlap, JAK2 positive MDS-MPN overlap. So how do we approach them?
Yeah. That is a great question. I'm actually seeing a patient just like that now. So honestly, I think there's this is really interesting. What's the mechanism? What is this disease and what do we call it, right? And then there's the practical question, how am I going to treat you here, right? So typically when I get an MPN MDS overlap, I'm going to look at the MDS side of things and I'm going to look at the MPN side of things. And I do this to better understand the disease and to actually find a target. So you do an MDS FISH panel, I'll do an MPN FISH panel, and I'll do NGS for sequencing. So, I mean, practically what I'm looking for is every so often there'll be a patient who has a PDGFR-A or a PDGFR-B rearrangement or amplification. And why do I think that's interesting? Because imatinib might actually be helpful in that situation. As you pointed out, you've got the JAK mutation. Well, maybe you could consider using ruxolitinib. And then, of course, you know, typically CML doesn't present that way, but you still have to rule it out with BCR-ABL. And so generally, you know, therapeutics, so a lot of times these patients present either with a proliferative phenotype or more of an MDS phenotype, right? They can vary. So some of them have really high white cell counts, and maybe you'll find a KRAS mutation or an NRAS mutation. Others of these patients will have more of an MDS phenotype. And so I kind of pick my therapies accordingly. I will say I have a clinical trial here. One of my colleagues has a clinical trial of, you know, one of the, you know, MEK inhibitors that actually targets RAS. And so for somebody who has KRAS or NRAS, I might say, hey, let's get this patient on a clinical trial with cobimetinib, which is the name of the drug. Trametinib is the other drug that's been used. For some of these patients with a more MDS phenotype, I'm going to choose a hypomethylating agents. If they've got the JAK mutation, you could say, well, should I go ahead and add ruxolitinib? I'll say there's data on that, but it's very limited. Sometimes it causes more cytopenia, so you have to be careful. For the proliferative ones, again, hypomethylating agents might be a choice. And then, as I say, I'm always looking, you know, for these PDGFR-A and B rearrangements. They're incredibly rare, but if you find them, then you could consider using imatinib because we know that inhibits PDGFR-A or B. And then if you see eosinophilia, and this is not the MDS MPN overlap, don't forget to look for these things too, because for the myeloid rearrangements, you might actually find PDGFR-A or B, and you'd be able to use imatinib in that situation.
Thank you. Dr. Swasti Sinha, please go ahead.
Hi, good evening, Dr. Vivian. That was definitely a most enriching update on ASH proceedings. Thank you for summarizing that for us. I had a question for those unfortunate cases of CML on TKI who go on and develop myelofibrosis. So for those subset of CML cases, we often face standstill with frequent TKI interruptions with anemia and leukopenia. So there is a trial and error approach with the danazol, ESA, hydroxyurea. So what do you think about it? And so what is your approach for these patients? And is there definitely a role for interferon in your experience? How do you place and where do you place interferon for such patients?
So I will say that my own patient population, there's a group of patients who have these severe cytopenias, which is difficult. I will say that I don't necessarily always see fibrosis, but you're absolutely right. We know our earliest patients with high risk is a CML that presented with fibrosis. And unfortunately, you really can't get rid of the fibrosis until you treat the underlying disease. So I think I personally haven't used danazol, but I think, you know, it is kind of intriguing to think that an erythropoiesis stimulator like danazol, you know, might be reasonable to do. I haven't used a lot of interferon and TKI combinations in this population. I think it's mainly because most of my patients don't have fibrosis. But the cytopenia stuff is actually a giant difficulty. And I think probably the hardest problem in the management of CML and the one where most of the disease progression happens is this group of patients who you can't treat because they're so cytopenic, and it's like a circle. You hold the drug, their cytopenias get better, you put the drug on again, they become cytopenic, and ultimately they just can't be treated. So what do? Well, I have access to a thrombopoietin, to TPO. So I use TPO mimetics for low platelets, and I use ESAs for anemia, and I use GCSF for neutropenia. And so what I do, and this is really anecdotal, is that I start at a low dose And I try to give the dose consistently, living with moderate to severe cytopenias with very close follow-up. I have argued with insurance companies, but thanks to Dr. Cortez for publishing this data, I usually can get for some of these patients L-trombopeg. And then I use the growth factors. It turns out CML is pretty sensitive to G-CSF for neutropenia, and you can also use ESAs for anemia. And so I kind of use this combination individualized to each patient and try to keep the drug on board. And the reason I try to keep the drug on board is for every patient where this succeeds, and I just had one of them succeed, once the BCR-ABL declines, the cytopenias get better. So it's the disease itself that's poisoning the microenvironment. And so if you can get a person to respond to therapy, and you may have to reach for a more potent therapy at a low dose, this plan works. Unfortunately, there's a group of patients, it doesn't work. No matter what you do, they have these low counts. And to be honest, I give up. I send them to transplant. But I think your idea of trying to think outside of the box a little bit and try danazol would be good. With interferon, unfortunately, I just get more cytopenias with my TKI. And so I struggle a little bit with making it worse rather than better. But I can see that that might be a reasonable consideration.
Thank you so
Thank
much.
you, Dr. Sastry. So next question is regarding again from the interferon related. The study shown that patient treated with interferon has consistent TFR. Do you suggest to start interferon before TKI and or along with TKI? And question number 2, do you suggest to use interferon to prevent molecular relapse during TFR?
Yeah. Well, I would say that the French and the German data, we have a lot of data on interferon plus TKI. So you get to responses faster. You don't get better responses. I would say I was a little bit underwhelmed with whether or not adding interferon to TKI as kind of like pulse doses or more consistent doses in the Tiger and Petal studies, necessarily improved TKI discontinuation success rates. I also think it has a lot of side effects. So at the end of the day, I haven't really reached for interferon. I agree. We get patients to deep responses, but so far, no matter what we do, we haven't really improved success rates, right? We still sit at about, 50 to anywhere from 40 to 60% of patients will succeed at TKI discontinuation to get to deep responses. If you've got a young person, as I said before, second generation is great because you're going to get there faster. But once you get to that goal, quite frankly, the success rates after you stop are the same, whether or not you add stuff or do stuff. So I still think that's an area we need to do a lot. We need to explore new options. And I don't know what those are. I don't know that starting frontline asciminib, for example, like we might be doing here in the US or EU in clinical trials, is really going to make us more successful at getting patients to succeed at TKI discontinuation. I'm pretty sure we're going to get to deep molecular responses faster, but that doesn't equal TKI discontinuation. But I haven't really found that adding interferon really helps very much. Although I know in the EU, there's a lot of ongoing studies looking at how to add interferon to stuff. So in my own personal practice, because of the increased side effects, I haven't been really adding it.
Thank you.
So I have you off track. But I will say I don't actually just stop you cold turkey. If you want to know how I stop patients, I actually kind of model the DESTINY study. So the UK DESTINY study was a study of mostly imatinib treated patients, but also some dasatinib and nilotinib treated patients in major molecular response and MR4, which is BCR-ABL of less than or equal to 0.01%. Then rather than stopping the drug for patients with durable responses, they actually cut the dose in half. So if you were on imatinib, you went to 200 milligrams, and then you stayed there for a year. And then you were eligible for TKI discontinuation. And at 3 years, 72% was the treatment-free remission rate. So a little bit higher than other things. And I also kind of like this dose lowering approach because I think maybe staying on drug longer with deep molecular response, and this is actually supported by clinical trials, actually will improve your chances at TKI discontinuation success. So my approach at this point would not be to add interferon, but is to keep people on drug longer and to reduce the dose. And I follow DESTINY generally in that.
Thank you. So next question is from Sitaram. In India, we see quite a lot number of younger patients with CML compared to Western world. Do you think would there be any possible reason for that? For this particular?
That was a great question. That was a great question. I know that studies are actually underway. The question is the biology of the disease different, right? Because there's also more advanced phase disease at presentation. And I think as someone asked earlier, there's also a lot more fibrosis at presentation than we see here in the US. So I will say, I don't know the answer. I know more patients present with advanced phase disease. I would say that they also present more frequently with adverse cytogenetics at presentation and possibly with adverse mutations. But I haven't seen that data summarized for a very large group of patients from India or Southeast Asia. And does anyone in the group know if that's ongoing at this time? Dr. Agarwal? Dr. Malhotra may actually know the answer to this question. So I know he's had some collaborations. I would love to actually be able to address something like that, in my lab, because I actually study mechanisms of CML disease transformation.
Yeah, so next question is from Dr. Savitri Singh. Ma'am, any experience of pediatric patient presenting with lymphoblastic crisis at the time of diagnosis? Then which TKI is the best?
Yeah, so great question. So I think, our standard approach for pH positive ALL and lymphoid blast phase CML is actually hyper-CVAD chemotherapy. So your choices are imatinib, dasatinib, and ponatinib. And so I would say the MD Anderson data, at least for adult pH positive ALL, makes a case that ponatinib is the more potent one. I would say more generally, probably dasatinib is the go-to in the US. So I would probably choose that one as the TKI to put together with hyper-CVAD. And of course, once they are in remission, head to transplant.
Thank you. Dr. Faima, any questions? Your hand is still raised.
I have a case to discuss with you, ma'am. We had a 38-year-old CML whom we had put on second-gen TKI with no molecular response. BCR-ABL levels were always above 21%. We did the sequencing as well, no mutations. Considering his young age and a 10/10 MSD, we went ahead with transplant. So now he is day 120 post-allo transplant, absolutely fine. So now the problem comes like, what should be the TKI I should be giving?
Yeah, great question. So if this were my patients and I'm lucky, I would actually put them on ponatinib for about 1 to 2 years after transplant. So I know that's not a very helpful answer for you. So which side? So you have probably bosutinib and dasatinib, right?
Yeah.
In India. And maybe a nilotinib if you asked for it. The problem with bosutinib sometimes is this GI side effects makes it really kind of hard to tell GVHD from bosutinib related side effects. And you said dasatinib before, right? And he didn't respond to it.
No.
Yeah. So I guess, you could, if you could get it from Novartis, you might try for nilotinib. I don't know, are there any clinical trials of vodobatinib in India that would allow him to go on study? I'm guessing not, because he's in remission. He would have to have evidence of disease.
Right now his BCR-ABL is 0%, ma'am.
Yeah, so I will say that the data for TKI maintenance after transplant is, a little bit of a wash. I would say for chronic phase patients who get transplanted with no disease, you don't have to use it. But for advanced phase patients, there is a hint that there is a benefit for doing some period, which most of us say is 12 months of TKI post-transplant. And it's usually the first year. So, you can make the argument how many days how far out from, he's 6 months out from transplant at this point, right?
Yeah.
So he's in remission. If you wait any longer, you could say, well, if you start it in year 2, is that really going to be a help or not be a help? So if you can't really have access to a drug, you could say, well, let's not do the maintenance. If it were me, I might try to see if I could get some nilotinib, and just complete another 6 months or another 18 months, just to be super safe.
Given him nilotinib, ma'am. He didn't
respond. All right, you
get
it. Oh yeah, dasatinib, yeah. And was this before transplant or after
This
transplant?
was before transplant.
Okay, did he get bosutinib too? Did you give him all three? Dasatinib, nilotinib?
He did not tolerate bosutinib. That was the main reason. He also
All
had underlying ulcerative colitis. So
All
that
right.
was the reason we could not continue on full dose of bosutinib as well, and we
All right.
transplanted him.
Well, all you got left is interferon. And so we know interferon was appealing in the post-transplant setting because there is a little bit of like amping up of graft versus leukemia effect. And these were data that came from the Fred Hutch in the old days where we did interferon and DLI for relapse post-transplant. But honestly, nobody really wants to take interferon, sometimes with the side effects. So I think if you do not have access to a potent third generation TKI like ponatinib, which is what I would use here, you could consider interferon, but I probably wouldn't do it. I'd probably just leave it and I would watch closely. Yeah.
Thank you so much, ma'am. Such an exciting input I got from you. Thank you so much.
Thank you, ma'am. I have a quick question. Just a scenario I'm discussing that we see very commonly in our clinical practice. So a young patient incidentally detected high hemoglobin. They are non-smoker. They don't have any organomegaly. Their heart and lung is fine. EPO, erythropoietin level is normal. JAK2 both XL12 and V617F negative. qPCR, BCR-ABL is negative. So at this stage, you just stop investigating the patient and say it's a secondary erythrocytosis or reactive erythrocytosis, or you further work up this group of patients?
Yeah, so two answers. Number one is, how about exposures like carbon monoxide and stuff like that? Any chance that this person has carbon monoxide toxicity or exposure to that might be driving this?
There is no exposure history or professional hazard history like that, so unlikely. Okay.
So usually these are high EPO things, but there's certain tumors, right, that lead to erythrocytosis. On the other hand, does he live at elevation? I once got faked out by a very small increase in hemoglobin because the person was like living at 5,000 to 6,000 feet of elevation. And so your hematocrit's also going to be a little bit higher. So what is the hemoglobin in this particular case? How high is it?
17.5, 18, like that.
Okay.
So it is more than 16.5, I can say. It's not 20 or 21, no.
So, JAK2 exon 12 mutations will actually present mostly with erythrocytosis with no elevation in white blood cell count or platelet count, which is different because usually if you have PV, right, you have elevated white cells and elevated platelets too. So you just looked for the V617F mutation, or did you look more broadly in exon 12 for mutations too?
So any other NGS or something you want to do?
Yeah. So you can. So if you only looked at exon 14 for JAK2 for V617F, there are mutations in exon 12 that could present this way. And then I would also collect a family history. I mean, there are familial cohorts, right, where you have high hemoglobin affinity and you need a higher hematocrit in order to deliver oxygen to the tissues. And so I guess I would ask for the family history then. But you're right. I would go through all of the different exposures, that you're looking for a reactive, right? And it sounds like that's been done. Elevation to testosterone, carbon monoxide, all of these things. And then ultimately, if I was still puzzled, I would think about exon 12 mutations, as a primary thing. And then if I really was not sure, you can do a bone marrow exam because there are clear features in the bone marrow, right? This is a myeloproliferative neoplasm. So if it's hypercellular, there's a skewing that might lean one way or the other. There are mutations, there are some other mutations, but they're very rare. And so.
Thank you. Dr. Pankaj?
Yeah, can you hear me?
Yeah.
I can.
Thank you. I want to discuss one case. It's a 13-year boy who has been adopted by the parents. They're not a biological parents. And he diagnosed with the CML. CP started with the imatinib. And after a year or 1.5 years, he progressed to CML blast phase. Started with a little bit of chemotherapy under dasatinib. And 1 year he was okay. and then again have a progression of relapse of the disease. And then he was started in ALL-like induction along with the nilotinib. There was mud was searched, but there was no actually matched unrelated donor at the time. And parents were also not so willing for the transplant. So with this, he went into the remission and he get the MR4. Now, what I should do, the parents are now willing for transplant. Should I search for the mud or should I continue with the nilotinib along with the maintenance phase of ALL-like therapy?
Great question. What's his BC variable?
BCR now he is negative MR4.
All right, so it's still detectable or undetectable?
It is from last 2 times it is undetectable.
Undetectable.
Yes.
What was the BC variable status going into at the end of the ALL induction phase?
So it has log reduction is there, and after consolidation, after 3-month post induction, it is undetectable. So it is a recent last 6-month story.
And how far out from how far is he into his treatment now for the lymphoid blast phase?
So it is around 2 years.
2 years. So it's 2 years since you'd started this, and so you have another year of maintenance, if not longer. Yeah, that's a tough one. So, for adults, MD Anderson makes a case that if you have an MRD negative remission, maybe, just using TKI maintenance, is good enough and you don't need a transplant. That is a hard one. I'm gonna, a lot of times we send our patients, I send most of my patients with pH positive, ALL, and we also send the patients with lymphoid blast phase CML to transplant. I think lymphoid blast phase CML can be a different disease than pH positive ALL. And so I've always favored transplanting all patients who have blast phase transformation. But I can see, the case here, well, kids in MRD negative remission. So what could happen, right? Well, you're going to have another lymphoid blast phase relapse and you're not going to be able to get them to transplant, right? On the other hand, transplant comes with a lot of comorbidities, obviously. Do you have any other idea about the cytogenetics and the molecular profile going into the lymphoid blast phase transformation? I mean, any worrisome cytogenetic or molecular features outside of the transformation?
Yeah, so when we search out for the resistance, there is no resistance. No other, as such, I remember any cytogenetic abnormalities other than this BCR-ABL.
Just on the pH. And do you feel pretty confident in how good your PCR is?
Yeah, PCR is actually reliable. We are doing routinely from that lab, and it is consistently routine. So we have this thing, faith in that lab.
Yeah.
Seems to be okay. And child is clinically fine. There is no now splenomegaly. Counts are normal. And he's getting this nilotinib along with the maintenance therapy of inhibitors.
Yeah. I don't know. Part of me still favors transplant. Honestly, I just think lymphoid blast phase is a tougher disease, and generally, I head to transplant. I feel what you're saying. It's like 2 years, right? And it's going to be 6 to 12 months, and possibly getting GVHD. I just worry. I don't know how successful your ability to salvage this will be. You could make the case that the longer out from your induction that you relapse, the more likely you are to be sensitive to exactly the same agents that you received, right? It's only the early relapses where it's really difficult to get them in remission. And so, if the parents are really unwilling, you could then consider any detection of BCR-ABL. I would just plan for transplant. Unexpected transformation, you're going to treat them again with the same regimen. Since it's been 2 years, you probably could use the same induction and head to transplant. But I just worry in this 13-year-old, who's not 67 years old, that if he relapses and you can't, that maybe just doing the transplant to get a good GBL might be very reasonable to consider. But I fully acknowledge there's not 100% right answer here.
Thank you, Dr. Dwivedi. Dr. Faima, any questions?
Nothing, sir.
Nothing.
I thoroughly love the whole webinar. I had a lot of unanswered questions in CML, and I think I really got closer to most of them. Thank you, ma'am. Such an
All right, well,
enlightening talk.
thank you so much for that feedback. Much appreciated.
So,
The group always has fabulous questions, and I think you have a lot of CML patients in India. So probably the most CML patients in the world, probably, right? So
We tried to make Jugaad, the Indian Jugaad, to manage things, and because we don't have access to most of the latest drugs. But I hope people are coming. Recently, I heard that we are having access to the Bangladeshi ponatinib. So it
All right.
costs 25,000 INR
Oh,
per month. So one of my PH positive BLLs are on ponatinib based induction. So
Yeah.
the best.
So if you can get ponatinib, I think there were some scenarios here. It really is, and I presented that data, just so people could see why sometimes the third generation TKI is really the way to go. Do you think vodobatinib is going to be something that you'll have access to moving forward? I know because it is made by Sun Pharma in Mumbai, so I was curious whether there would be access to that drug too.
I
since the-
hope we do, ma'am, but not to my knowledge, not as of now. What we have is generic ponatinib, which is imported from Bangladesh right now.
Right. Good. Generic ponatinib. I know in the US, we don't even have generic dasatinib yet. We only have imatinib. Everything else is high cost. So,
any other questions from the panelists? I think you have answered all the questions. Fabulous. 1 hour, 20 minutes continuously you were speaking. So I just thank Mrs. Lekha, Mr. Rahul Deshpande and team Novartis, Mr. Yash Kalpesh and team Perfect Square, Executive Committee of MHG, and most importantly, our guest speaker, Dr. Vivian from the Seattle. Excellent talk, madam, really, and all the questions you answered very lucidly, and all our discussions who are themselves eminent hematologists and medical oncologists. Tomorrow there is one more meeting from 11:30 AM onwards, 2023 updates on T-cell lymphoma. Speaker will be Professor Fellini. He is a director of Institute of Hematology and Bone Marrow Transplantation, University of Perugia, Italy. So thanking again all, and we just thanking madam for your lovely lecture and then time spent with us. Good evening.
have a great evening, everyone.
Thank you, ma'am.
All right.
You, Dr. Vivian. Right.
Take care.
And thank you, Sanyal, for anchoring the whole program. Thank you. Bye.
Thank you. Thank you, ma'am.
All right. Have a great weekend, everyone. Take care.
Take care.
Bye.